Little to
Hello, how's it going?
Hi.
Hey, Jonah.
Pause the recording for a sec. Call. And we're just going to wait maybe another minute for folks to trickle in, any other outlets, and we will begin.
Rachel, Susan wanted me to cover quite a bit. I will absolutely do my best to stay within 2.3 minutes you give me.
Sounds good. Sounds good. Do what you can.
I think we're going to get started, and if other folks trickle in, we can always welcome them. So thanks everybody for joining us. My name is Jonah Allen. I am with the Brooklyn Borough President's Office. We want to thank everyone for coming on today to hear about this new report that we are releasing in partnership with the Harvard Law School's Food Law and Policy Clinic on ways to advance nutrition education for physicians and healthcare professionals. Just to sort of set the stage, we are going to hear first from the Brooklyn Borough President, Eric Adams, followed by the Harvard Law School Food and Policy Clinic, Food Law and Policy Clinic. And then we're going to hear from the Physicians Committee for Responsible Medicine, and then the American College of Lifestyle Medicine, and then we'll open it up to questions if there are any. I want to remind folks, just keep yourself muted when you're not speaking, if possible, and feel free to chat me, members of the press, if you have any questions you'd like to ask. But with that, I'm going to turn it over first to the Brooklyn Borough President, Eric Adams.
Thank you so much, Jonah, and I want to thank my team member Rachel as well. And I want to give a special thank you to Harvard Law School Food Law and Policy Clinic, Physician Committee for Responsible Medicine, and American College of Lifestyle Medicine for this important announcement and this important endeavor and report. We have said for a long time, when you look at chronic diseases, it's not your DNA, it's your dinner. It's not where you're born, it's your breakfast, and it's not your lineage, it's your lunch. Food matters. And today, the releasing of a report with the Harvard Law School Food Law and Policy Clinic. We will be releasing this report to show how to improve nutrition education for physicians and healthcare professionals. Currently, physicians receive little to no formal education on nutrition and how it impacts health. That means patients suffer from a lack of knowledge about how they can use diet to prevent and even reverse certain chronic diseases. Many of you know that not only do I believe in what's in this report, but I also was able to reverse my diabetes based on the data and the information that's coming out from a report of this magnitude. Diet is the most significant risk factor for chronic diseases and premature death in the United States. Heart disease, cancer, stroke, and diabetes, all highly correlated to diet, are among the leading causes of death. It also increases some people's likelihood of becoming seriously ill or dying from COVID-19. We heard it all the time during the coronavirus pandemic, that over 90% of the people hospitalized had comorbidities, and over 90% of the people who died from coronavirus also had comorbidities. That's a fancy term for just heart disease, respiratory illness, diabetes, many of these chronic diseases we see. A July CDC study showed that nearly 40% of the people who had died with COVID-19 had diabetes. Among deaths of those under 65, the same study found half had the chronic condition. That is an astonishing number for something that food can treat and in some cases even reverse. This pandemic has exposed how fragile our healthcare system and how wide the disparities between healthcare facilities that leads to unequal outcomes, the need for greater centralized coordination, and the prevalence of underlying conditions in certain communities. It is clear. But it also has exposed how little emphasis we as a society place on nutrition. This is a personal conversation that I know far too well. We can do better. And I know we can do better by looking at the report and its recommendations. The report we're releasing today offers a roadmap for policymakers on how to ensure we put nutrition and diet at the center of our conversation and not just on the peripheral. We don't only have a health crisis, we have an information crisis, and it's imperative that we close that gap. And so I want to thank Harvard Law School for their partnership with our office on this important project. And I will now turn it over to the team as they go through what is part of this report. Again, thank you very much.
Emily and Suzanne, feel free to go ahead.
Perfect. Thank you. Thank you so much for that introduction. I think I'm going to wait for Suzanne to share the slides and then I'll get started there. Okay. Thank you. So I'm going to just kick us off and introduce the report a little bit, and then I'll turn it over to Suzanne, who is a student in the Food Law and Policy Clinic and has been working with me since January on this report and all of the research. The Food Law and Policy Clinic educates students about the laws regulating the food system and offers them an opportunity to work on real-world pressing issues around food and its impacts on health, sustainability, and equity. So in addition to students working on projects like this, I teach a course on food law and policy. And several years ago, a Harvard medical student enrolled in my course. And he was a great participant in the course. He brought so much to it. And a couple weeks in, he said to me, "Don't you think it's strange that I have to cross enroll in a course at the law school to learn anything about food and diet?" And I said, that is strange. So I went home and I was thinking about this and thinking about how bizarre it is that a student, he's going to be a doctor. He wants to understand diet and nutrition, to teach it, to talk about it with his patients. Can't find anywhere to take courses about this. So I went home and talked to my father, who happens to be a physician as well, who's a gastroenterologist, and he also confirmed that as a practicing physician, there was no point in his education where diet and food and nutrition were part of that discussion. So we look to doctors to be able to help us make decisions that will keep us in good health, especially when it comes to diet, and which impacts so many of the most common and costly diseases facing our society, and is also applicable to all patients. It's therefore shocking to learn that doctors are no better equipped to provide this advice than your non-medically trained friends, neighbors, etc. So I'm so grateful to be here today and for the partnership with the Brooklyn Borough President's Office to bring attention to this issue and develop recommendations for the future. So just to give a little bit of background, as you heard already, diet is really the most significant risk factor for so many issues related to disability and premature death in the US. Heart disease, cancer, stroke, and diabetes are all highly correlated to diet and are among the leading causes of death. In New York, almost 63% of adults in New York State and over a third of children are overweight or obese. Diabetes is also the state's most rapidly growing chronic disease, affecting 1 out of 12 New Yorkers. Cardiovascular diseases are the leading cause of death in New York, killing almost 59,000 of the state's residents each year. And lastly, as you just heard so eloquently, in the midst of this COVID-19 pandemic, the fight against diet-related diseases has become even more urgent, as individuals with diet-related conditions have been especially impacted. As one data point, obesity alone increases the risk of dying from COVID-19 by up to 48%. And more broadly, diet quality has strong impact on immune function. New York has a really strong incentive to take preventive measures to address the rising prevalence and cost of diet-related disease. And as you heard as well, these impacts aren't felt equally and really worsen the disparities already that so many people across the country and in New York are facing. So although many people consider physicians to be a trusted source of information on the relationship between diet and health, in actuality, physicians generally receive little or no formal education on the topic. So as you can see here, in terms of medical school, less than 1% of lecture hours are offered on nutrition. Medical schools generally don't meet even the minimum guideline that the National Research Council has suggested that schools offer at least 25 hours of nutrition education. Schools are not meeting that. In terms of graduate medical education, which is the fancy term for residencies and fellowships, there's no nutrition education in the program accreditation standards, which means that there's no requirement, even though a lot of government dollars, both state dollars in New York and federal dollars, go to support graduate medical education. So accreditation standards for most residency programs don't mention food or diet or nutrition at all, except in the context of the resident's own well-being. So noting that it's important for residents that they get enough sleep and that they're eating well, but not that it's important for them to be learning about diet and food to talk to their patients about it. And then lastly, once physicians are licensed, they have no continuing medical education requirements in any state right now that are specific to diet, nutrition, or food. So what's the result of this? Not surprisingly, 73% of physicians report that they receive no or minimal instruction on nutrition. And this is even true across specialty areas that you would think nutrition and diet would be really important. So 90% of cardiologists, for example, recall receiving no training on diet or nutrition. And 86% of practicing physicians report that they feel unqualified to offer nutritional advice to their patients. This means only 14% of physicians feel that they can have an adequate conversation about diet or nutrition with patients. With the lack of nutrition education for doctors, there's really a missed opportunity to fight diet-related disease, because doctors who are trained in nutrition and diet and nutrition counseling are more likely to include nutrition assessments during their patient exams, to communicate at least accurate basic nutrition advice when asked questions by their patients, and most importantly, to make referrals to dietitians when those would be the recommended course of action. We need our doctors as the first line of defense to be appropriately armed with the information to keep us healthy. So since 2017, we've been collaborating with the Nutrition Education Working Group, which is a group of medical and public health faculty at Harvard, Northwestern, the Cleveland Clinic, and the Gaples Institute, to map out all the different opportunities to engage physicians to help patients improve diet and have better health outcomes. And this culminated in a report last fall called Doctoring Our Diet, Policy Tools to Include Nutrition Education in US Medical Training, which really looks at some of the national level opportunities. And we were able to have a congressional briefing to discuss some of those points. And then today we're releasing issue briefs, both one on New York that we did together with the Brooklyn Borough President's Office, and then one also on Massachusetts. So I'm going to actually turn it over to Suzanne to give you some of the highlights from the New York issue brief.
And Suzanne, you're still.
Can you hear me now?
Yes.
All right. So thanks, Emily, and thanks also to the Brooklyn Borough President and his office for giving me this opportunity to research and present ideas and suggestions. So our issue brief outlines 10 policy options that New York State and the New York City governments could pursue to make nutrition education part of physicians' training. This issue brief offers a broad range of opportunities for policymakers to consider. Given the strain on the healthcare sector during the COVID-19 pandemic, we acknowledge that immediate action may not be feasible for some of the policy opportunities outlined in the brief. However, some of the opportunities could be actionable in the near term. And I'll focus now on some of the options that we think are the most feasible, all of which we highlight in the executive summary to the issue brief. Then later on, I'll also introduce a few of our longer term options. So the first option is technical assistance. The state legislature or city council could create offices within their health agencies to provide technical curricular assistance to improve nutrition-related programs and curricula in health professional training programs. Once created, these offices would be dedicated to researching and promoting effective nutrition-related curricula, establishing core competencies in nutrition for graduates of the programs, and disseminating information on best practices, including highlighting innovative and already existing programs. As an alternative to creating an office, the state legislature could direct an advisory group to manage physician nutrition education resource centers that would similarly distribute information on best practices. There are lots of resources already out there that medical schools and teaching hospitals could use as a starting place. And so just helping to gather and disseminate these resources can help remove a significant hurdle in more schools following suit. The second option is licensing requirements. So the New York State Office of the Professions, which is the state regulatory body that licenses New York physicians, it plays a key role in shaping the continuing education of practicing physicians. So what it can do is amend its regulations to require that physicians have nutrition education in order to be licensed to practice in the state. So the Office of the Professions can require training in nutrition and nutrition counseling as a one-time requirement for physicians' initial licensure. And they can also require physicians in the state to take nutrition education courses regularly as part of their continuing medical education or CME requirements. So what this would do would make sure that no matter where physicians practicing in the state have been educated, when they come to the state, they have to know some basic level of information about nutrition to become licensed. And then every few years, they would receive up-to-date information through their CME requirements. States across the country already have CME requirements for specific subjects like opioids and pain management. New York could be the first state to offer nutrition CME requirements, but it certainly wouldn't be the last, as there's a lot of momentum in this direction. California already does encourage physicians to take CME in nutrition, if not require them just yet. And Washington, D.C. includes nutrition in a list of CME priority areas for physicians to definitely focus on when choosing their CME courses. So the Office of the Professions can get the ball rolling without causing strain in the short term by making the necessary regulatory changes now, but then specifying that they'll go into effect in a couple of years. So our third option is that the New York City Council could pass a resolution. So resolutions are not binding, but they express the sentiment of the city and thus have significant symbolic value. The resolution could acknowledge the impact of diet-related diseases on COVID-19 and highlight the lack of nutrition education at all levels of medical education. It could then urge health professional training programs to consider increasing class and clinical hours devoted to nutrition education and practice, and also call upon city government agencies to raise awareness of the responsibility of physicians to promote healthy diets and to be equipped to learn how to do that. So there are a lot of constraints on the healthcare system and the state budget right now. But in the longer term, looking past the COVID-19 pandemic, here are some of our recommended policy options. First, New York could create a nutrition education grant program for medical schools and GME programs aimed at increasing nutrition education for physicians. And this grant program could provide funds for schools that invest in nutrition curriculum, conduct nutrition-related research, or hire nutrition education faculty. Grants would infuse money in a more targeted manner towards a smaller number of programs, with the goal of those programs becoming models for future programs. While grants could be difficult to fund due to the current budgetary situation or even in a few years, The scale of the program can always be tailored to New York's current financial resources at the time. Alternatively, the New York State Department of Health or the City Department of Health and Mental Hygiene could create a challenge to encourage in-state medical schools and GME programs to commit to increasing their nutrition-related curricula and programs. Programs that accept the challenge would then regularly report to the agencies on their progress and then receive technical curricular assistance to help them as they try to meet the challenge. So the challenge could potentially award a small monetary prize and definitely also positive recognition awards to all the programs that achieve the desired level of nutrition education. Lastly, another example is that the New York State's Department of Health could condition its use of Medicaid funding of residency and fellowship or GME programs on nutrition-related benchmarks. New York State used $1.69 billion of Medicaid funds in 2018 to reimburse some of the educational expenses of in-state GME programs. These funds could be tied to certain performance benchmarks, including offering a certain amount of nutrition education and having graduates that have met a certain competency in nutrition, as well as other performance benchmarks. This incentivization structure could encourage GME programs to meet the nutrition benchmarks so that they can receive their vital Medicaid funds. So these are just some of the many policy options we've outlined in our report. We've taken care to lay out a variety of options, a full menu that we believe could all make a measurable impact on the health of New Yorkers. Again, we're grateful to the Brooklyn Borough President's Office for all their hard work in this area, and we really look forward to supporting them in the future. Thank you.
Thank you, Emily and Suzanne, for that. We appreciate it. Next, we want to hear from Min with the Physicians Committee for Responsible Medicine.
All right, thank you all. My name is Min Nguyen, registered dietitian with the Physicians Committee for Responsible Medicine. And as President Eric Adams and Emily discussed, nutrition plays a critical role in the prevention and treatment of chronic diseases. This is it's especially important now during the COVID-19 pandemic because COVID-19 claims the greatest casualty among those whose bodies were already severely affected by chronic inflammatory diseases. These non-communicable diseases are the world's leading killers and increases one risk of severe illness from COVID-19. We're talking diseases like cardiovascular disease, like high blood pressure. According to data from the CDC, people with high blood pressure are 3 times more likely to get hospitalized compared to people who without high blood pressure. Another chronic disease, diabetes, again, 3 times more likely to get hospitalized. Obesity, 3 times more likely to get hospitalized. Now, those with 2 or more of these conditions are 4.5 more times likely to get hospitalized. And then those with 3 or more of the conditions, actually 5 times more likely to get hospitalized. And our patients often have more than one of these diseases because these chronic diseases or lifestyle diseases, as we call them, stem from the same root cause, or diets. Now, a healthy diet centered around plant foods may be able to prevent and treat heart disease, hypertension, diabetes, obesity. Again, these are all conditions associated with increased risk for severe illness from COVID-19. But unfortunately, the prevention of chronic diseases through diet and nutrition is an area of medicine which most doctors receive little or no instruction during their medical education and training. Therefore, they lack the adequate knowledge to be able to inform and advise their patients. And by addressing these chronic diseases, we're able to help move our patients or loved ones further out of that high risk zone for COVID-19. Thank you.
Thank you, Min. Appreciate it. Our last speaker will be Jennifer with the American College of Lifestyle Medicine. Jennifer Trill.
All right. Are you able to see my slides?
Yes.
Yes.
Good. Thank you, President Adams, for having me and the American College of Lifestyle Medicine here, as well as Rachel and President Adams' office. I am at the University of South Carolina School of Medicine, Greenville. I'm a founding faculty member at U of SC Greenville, to where we implement over 80 hours of lifestyle medicine curriculum requirements to all medical schools that matriculate into our program. I'm representing American College of Lifestyle Medicine, and in particular the UME Task Force, of which we'll go over a number of things that we as the UME Task Force have been working on to very much align what President Adams' office is looking at for undergraduate medical education. So we are very familiar with American College of Lifestyle Medicine, who demonstrates that there are 6 pillars of lifestyle medicine, including nutrition, exercise, sleep, tobacco, healthy relationships, and stress management, where of course nutrition very much trumps all. So I am a PhD and a postdoc in clinical exercise physiology, and I'm always stating to the students, you cannot out-exercise your diet. So it's extremely important of how we discuss this with our medical students in our continuing medical education. As part of a member of the UME Task Force of ACILM, we are developing medical standards around undergraduate medical education, and there are a number of us from different schools that are working toward this. And what we are particularly looking at is what we have done in our own schools. So AT Still University, Harvard Medical School, Loma Linda University, University of Oklahoma College of Medicine, and of course our U of SC School of Medicine Greenville. All of us have implemented some portion of lifestyle medicine, in particular nutrition, across our curriculum. So some of us have a track or a specialty. Some of us have a core curriculum like our medical school. Some of us have lifestyle medicine elective courses. Some of us have lifestyle medicine interest groups. So we'll go into that in quite a bit. What we've learned over about a year and a half of pulling together the information regarding the success and the challenges of implementing lifestyle medicine into undergraduate medical education is at each one of these levels. So looking at the curriculum, looking at the institution, the administration, the faculty, and the students. And across the board, I would mention that many deans of medical schools are looking at the Step 1 exams, they're looking at residency placement. In faculty in particular, the stakeholders, there doesn't seem to be enough time to implement lifestyle medicine, or that is a perceived challenge. And with students themselves, they're really focusing in on that Step 1 exam after their second year in order to get into clerkship. So there's quite a few lessons that we have learned across institutions looking at our success strategies as well as perceived challenges. With the UME Task Force, we are creating this educational pathway through American College of Lifestyle Medicine, demonstrating that from what we've learned, there should be approximately 100 hours of lifestyle medicine training in the UME, and then of course close to 400 or more hours in residency training. You can see in this particular medical school at the UME, there's a jagged edge here that demonstrates that even though this is stating 40 didactic units and 60 application activities, this would be something that was adaptable to each medical school to determine what best worked for their curriculum. Because each medical school, and having gone through LCME accreditation 3 times now, it's very important that faculty own the curriculum. So we don't want to necessarily look at demanding or requiring exactly what that educational pathway would look like, and giving some adaptability to that with goals. So when we look at the standard educational hours that would demonstrate that curricular pathway, you can see each one of the 6 pillars of lifestyle medicine is in there, and primarily looking at this row 3 with nutrition, there's quite a bit more nutrition, both didactic hours and application hours, that are recommended by the American College of Lifestyle Medicine. And this also is very incongruent with the ACLM, ACPM, the core competency, and also the board exam for residents who want to sit and become board certified in lifestyle medicine. We're looking particular to support undergraduate medical education and medical schools on how can they accomplish increase in nutrition and lifestyle medicine education in their curriculum by not using the stick, but using the carrot. So how are we able to apply a bronze tier or a silver tier or a gold tier or platinum tier, and working with undergraduate medical schools to determine where they are and how we can help them move forward in tiers. ACILM in general offers quite a few educational materials across the continuum of medical education. So you can see bachelor and pre-professional level, all the way through undergraduate residency, CME certification, and maintenance of that certification that I had mentioned before. And a couple of those examples are the Lifestyle Medicine 101 that was developed by Beth Frades at Harvard University. And this is in working with bachelor's degree and pre-professionals that have not yet made it into medical school. There is a new culinary medicine curriculum download that anyone can get access to. There is of course, the Lifestyle Medicine residency curriculum that has been around for approximately 4 years now, that Loma Linda Lifestyle Medicine Education Collaborative, of which I'm a co-director of, and ACILM have all put together to help with that didactic and clinical application to be able to sit for the board exam. Very recently disseminated is the new online course, Reversing Type 2 Diabetes, which I do believe the president would be interested in reviewing with moving forward with education, because it sounds as though he has walked the talk for sure and understands how to reverse diabetes and to be able to advocate for this for our individuals. And then finally, we have the physician health and professional well-being that allows for that fourth component of physician wellness and health. So thank you very much for the time and for the opportunity to be able to present what we do at ACILM.
Thank you, Jennifer, and thanks to all the folks for speaking. At this time, we are open to taking any questions there might be for the Borough President or anyone else who's just spoken. Feel free to unmute yourself and ask the question directly, or you can write it in the chat and I'll read it aloud. But again, we want to thank you all for joining us. And another housekeeping item I'll mention, just while we wait, if anyone has any questions, is that we will be circulating a link to the recording. We'll be putting it up on YouTube and circulate that to all those who are curious to have it, and which will also have a link to the recording.
Hi, this is Suzanne from Greening for Life. I'm wondering if you've experienced, hi, I wonder if, you know, the forces at work that cause the medical institutions to be the way they are the forces that continue to work against, alternative medicine. So has anybody experienced any pushback or of any way of pharmaceutical companies saying there's no room for, you know, this in this curriculum?
I don't know how you guys want to handle answers. I'm happy to hop in, and then I don't know, you know, Jennifer, if you have other input to give on that. Not so much from, you know, the pharmaceutical side, but I think medical schools themselves, you know, would say there's so much already in the curriculum. It's really full. We don't have room for this, and you know, I think that my response to that would be that diet and food impact every single patient that walks through the door of your office. And there's nothing kind of more foundational than that. It has a role to play in almost every medical condition that, you know, that medical students and doctors will go on to see. So, you know, I do think that it will require hard work. And I love the slide and sort of the details that Jennifer mentioned that the American College of Lifestyle Medicine is putting down on making that easy for schools to do. I think our side of it is also empowering policymakers to say government dollars are going to fund medical school and graduate medical education. And then on the other end of that, patients are suffering, that there's a human cost to it, there's an economic cost to diet-related disease, that these dollars aren't being well spent on education that's not helping to prevent and treat those illnesses. So, again, there's certainly pushback. There's pushback for, lots of other reasons too, but I think it's really a matter of the political will on the part of policymakers and on the part of those involved in education to take a stand, knowing how important this is.
Mm-hmm. And thank you, Emily. I'll piggyback on that for Suzanne. So having done this for 8 years and founding the Lifestyle Medicine Education Collaborative with Harvard, we really took an assessment of what undergraduate medical education is looking at in terms of being able to implement lifestyle medicine into the curriculum. We have not ever had any issues around pharmaceutical companies butting up against that. It's much more, as Emily had mentioned, at each one of those stakeholder levels of curriculum, institution, administration, faculty, and students, primarily looking at the institution itself. It's not something that is typically thought of. So one of my very dear friends at Harvard, Eddie Phillips, he's the Boston VA medical director. He remembers going to school and stating, I was waiting for this education and I received 30 minutes of a walking class that talked more about the biomechanics of walking than it did actually the healthy outcomes of walking. And we have noticed through the years that we have had both our medical school and Lifestyle Medicine Education Collaborative and ACILM, that it is not on the forefront of thought. So we have a disease management healthcare system right now. We don't have a healthcare system. And we also have a disease pathophysiology education platform for most undergraduate medical education schools. And we have to be able to turn the tide for that, because I can tell you that many, many medical students are looking for this education. So if President Adams, if it helps us in any way, we opened our doors with approximately 1,000 applications for 100 slots. We now have over 4,000 applications for 100 slots. And the vast majority of the applicants are looking for the lifestyle medicine content. So I do believe that medical students are a huge champion for this. The other thing as well, Suzanne, is the board exam is a perceived barrier. And when students are looking at residency placement and wanting their top choice, whether it's dermatology or surgery or primary care, they have to do well in that exam. Now it is changing to a pass-fail as opposed to the number, which will be helpful. It certainly will be helpful. But deans and institutions were traditionally looking at that. Their benchmark of success is looking at those exam numbers, graduation rates, and there are not nutrition-based, they're getting better, but they're not nutrition-based LCME, NBME questions on those step exams. So we're working on that as well.
I can just add one data point that I think builds on what Jennifer said, that 72% of first-year medical students believe that nutrition and diet are highly relevant. But by the time they graduate from medical school, because diet and food are never mentioned, less than half of them still believe that this is important for healthcare. Absolutely. So we're clearly we're going in the wrong direction by what's coming out of medical education, and so I completely agree. And one other thing to say too, which is I think that a lot of schools there are a lot of innovative programs out there, and I believe the Brooklyn Borough President's office was putting together a document with some ready to go curricula that schools can use. I think my concern is really just that this can worsen disparities too. If there's some schools going way out ahead, and then there's a bunch of schools that really aren't, we end up with, this doesn't become a baseline thing that medical care includes and that's available to all patients. And that really, I think, is going in the wrong direction.
Again, thank you all for your partnership and continue this conversation. This is so important when we look at our healthcare system has really turned into just sick care and not really showing the power of lifestyle changes. Our system must have an intervention and a prevention plan. And if there's only intervention and not prevention, such as lifestyle changes, as you have mentioned, we're not going to turn the tide. Our system is not sustainable. With the 80 million, 30 million Americans are diabetic, 84 million are pre-diabetic, 80 cents on the dollar to chronic diseases. As we engage in this national conversation of access to quality health care, we need to start in our medical schools by teaching the power of nutrition. And I thank all of you for your contribution on this, and I thank the press for joining us today.
Thank you all. We're going to wrap up. Again, we want to thank everyone for joining. If you have a question that wasn't answered, you can just email me at jonah.allon@brooklynbp.nyc.gov. Thanks so much and have a good rest of your day.
Thank you.
Thank you.
Thank you all.